I've heard that in CBT dismantling studies, and I think this may have been the behavioral activation versus cognitive therapy studies, I'm not sure. It is not the cognitive restructuring that has significant impact. What is your take on this?
So, got to go back to formulation. You have to formulate the case, and oftentimes you're helped by the theoretical formulation of that particular disorder. And so let's say it's a depressed case, and he's severely depressed. You don't have him fill out a thought record, do you? If the person's severely depressed, to use what I described in my 1980 book as behavioral activation, you give the patient a schedule. You work with the patient collaboratively in preparing a schedule. And then you try to engage the patient in following. So engagement is very important. You try to engage the patient in trying to follow through. Now, if they're severely depressed, they're going to think that that's not going to do them any good. And you might even start the behavioral activation right in the office. There's one time I was asked to see a patient over at the VA, and he'd been in bed for months, maybe years, and they just couldn't get him going. And he was really hopeless. That was the whole thing. And if anybody tried to get him to do something, he would just kind of give up on it. And so I then asked him a question. I said, what do you think, what would you think if I told you that if you followed a few simple instructions that you'd be able to get out of bed and you'd be able to play ping pong with the other patients and so on? And he said, I think you're crazy. And so I said, would you like to test that out? And he said, test what out? I said, whether I'm crazy or not. Well, that really got to him, and that intrigued him. So then what I did with him is I said, why don't you sit at the edge of the bed and try to put your 2 feet down? And he said, well, okay, I don't know what good it's going to do. I said, what? You agreed that you're going to test out whether I'm crazy or not. So I said, okay. And then I said, will you try standing up? And he said, if I stand up, I'll fall. And I said, but that's okay. I'm going to hold you. So then I held him, and then he took a few steps, and he took a few steps more, and then he got tired, and he came back. And I said, well, what did the experiments show you? And he said, oh, I don't know. What was it supposed to show? I said, whether I was crazy or not. He says, well, maybe you're just a little psychotic, but not totally crazy. But anyhow, so this demonstrated, so I started really right in the session. This then demonstrated to the rest of the ward personnel what they could do with him. And it's true, a week later I came back and he was indeed playing ping pong with the other. So anyhow, severe patients, you want to use activity scheduling. Moderate patients, you can use the thought record with them, or you can use a whole lot of other things with them. Now, let's just say they don't respond, though, to the thought record. Well, there's a whole approach that you can use, which is similar to what I've been talking about with the schizophrenic patients, and that is to get them invested in something outside themselves. And this is particularly true of the depressed patients who are ruminators. If they're ruminators, all of their attention is directed inside. And so you can do simple refocusing techniques, like something we call the look, point, name. Have them look at something, point to it, and then name it, which is a simple thing. But a far more profound approach is to get them invested in something other than themselves. A few years ago, I saw a doctor who was moderately depressed. The reason for his depression was twofold. One is he hadn't gotten a promotion that he expected, and the second thing was that his wife had just decided to go to work, and he wasn't getting as much support from her, and he started to think maybe she didn't care for him so much. And so he's seeing the patients, and he says, "This is just humdrum. It's just a routine thing. I'm like on an assembly line." And then I said, "I want you to focus on each patient that you see, and put down whether you're getting pleasure or sense of mastery from each patient." And he said, "Well, what's the sense of doing that?" And I said, "Well, look, there are reasons why you wanted to become a doctor." And he said, "What were the reasons for it?" He said, "Because I like to help people." So I said, "Okay." So then when you're seeing your patients, ask yourself each time whether you think you're helping the patient or not. So what I did is I got him reinvested in something that had at one time been significant to him, but had been flooded over by his depression. So the way to break through this tidal wave, as it were, was to get him again invested in something outside of the tidal wave, and that's what did it. So there are a whole lot of other methods that you can use, but it's based on the formulation. So while the first thing that I did when I made my sea change to cognitive therapy was to think in terms of the thought records and looking for alternative explanations. Still a very powerful technique, but it's by far not the only technique, and there are a whole variety of other things. And with experience, you get a sense as to what's most likely to work with a given patient.
And so with severely depressed patients, it may have been true of this study, I'm not sure. If you are trying to do cognitive restructuring with a severely depressed patient, you're not doing good cognitive therapy. You need to be doing the behavioral activation.
Right. And behavioral activation is a form of cognitive restructuring because these people, as that patient I described to you, believed that he wasn't be able to be mobile again. And so by doing things, they get a real physical sense of being mobile, being able to be in control of their own body, as it were. And this has a very powerful reversal effect.